Today we talk about social power and how it shows up in healthcare systems. People experiencing racist stereotypes, like a Price is Right style guessing game in the emergency room about the blood alcohol levels of Indigenous patients. That's a power story. Whose bodies are treated as credible, whose pain is minimized, and who is presumed to be intoxicated. Our goal isn't blame, it's understanding how these dynamics shape care pathways and the administrative data that follow. By the end of this module, you'll be able to see how power shapes healthcare, from one-on-one interactions to system-wide structures, and how that affects who moves easily through care and who doesn't. You'll recognize how racism, colonialism, ableism, and geography create predictable barriers, or shortcuts, for different communities. We'll connect those dynamics to administrative data, what gets recorded, what's missing, and why that matters. And importantly, you'll leave with practical ways to apply intersectionality in your work, asking better questions, and working with partners to ensure equity is reflected, not erased. Here's the bridge to administrative data work. Every record starts with a human interaction, someone deciding whether you fit the system, what questions get asked, what gets documented, and what doesn't. Those choices are shaped by power, clinical authority, institutional rules, social norms, and the time and resource constraints built into the system. When the interaction is unsafe or dismissive, people may avoid care, delay follow-up, or disengage, which changes what shows up in the data. Researchers often meet these realities later as missingness, non-compliance, or loss to follow-up. In this module, we'll map where power shows up along the care journey and then connect it to how health data get created, coded, and interpreted. Let's ground a few terms in plain language. Power is the ability to influence decisions, access resources, and set the quote-unquote default rules. In healthcare, power shows up at 3 levels: interpersonal, such as how a clinician treats you; institutional, including policies, forms, and workflows; and structural, referring to colonialism, racism, ableism, and economic systems that shape who gets what, where. Privilege is not a moral scorecard. It's the unearned ease that comes from being aligned with what the system expects. Barriers are not personal failures. They're predictable frictions created by systems. Now we'll walk through a typical care journey, deciding to seek care, getting in the door, triage, history taking, tests, diagnosis, treatment, discharge, and follow-up. Power can shift at each step. Who is believed, what symptoms are taken seriously, how risk is framed, and what options are offered. System design matters too. Appointment systems, ID requirements, security practices, and standard discharge instructions can assume stable housing, English fluency, or access to transport. The In Plain Sight review outlines how Indigenous-specific racism becomes routine through stereotypes and system practices. It describes common stereotypes, such as assumptions of being intoxicated, drug seeking, or so-called frequent flyers, and connects these ideas to poor care journeys, including long waits, denial of service, and inadequate pain management. It also reports that some Indigenous respondents felt not at all safe in certain hospital interactions. Those experiences matter for data. If people delay care or avoid returning, the administrative record will capture fewer encounters and later more severe presentations. For analysts, this can look like low service use when it's actually unsafe service, or assuming a population is biologically vulnerable to serious conditions, rather than how the policy and social environment negatively impact their care. Context is not optional. It's part of validity. 2S LGBTQIA+ care illustrates how power can be built into everyday workflows. A Canadian review describes inequities in access, inclusivity, and satisfaction, driven by discrimination and by system design. It notes that fear of stigma can lead to non-disclosure of sexual orientation or gender identity, protective short-term, but increasing risk for care quality over time. It also highlights structural issues like cisnormative forms and gatekeeping in trans care pathways. One practical takeaway: training gaps. The review argues that limited education for both clinical and non-clinical staff is a critical driver of inequitable experiences. For analysts, this becomes a measurement problem. When people can't safely disclose, marginalized groups are erased from the data. Disability is another place where default care can quietly exclude. The MI Ableist Guide names key drivers of disability-based discrimination, clinical assumptions, apathy, and lack of knowledge, and links them to limited access, substandard care, and dehumanization. It also reminds us that health professionals hold real power over access to resources, especially when documentation is required to qualify for supports. Ableism can show up as treating accommodations as optional or speaking past the patient to someone else. For administrative data, these dynamics affect what gets documented about function, communication needs, and disability status, and what gets left in free text or never recorded. A helpful reframing: ask what the environment needs to change rather than what the person needs to overcome. What does this mean for the data we analyze? Nancy Krieger describes a two-edged sword of data. One edge is failing to collect or use data in ways that would document injustice. The other is collecting data, but using categories or interpretations that could cause harm. Her point is data for health justice. A Canadian example is the SPARK tool, created because primary care often lacks standardized data on social determinants of health. SPARK developed standard questions and implementation guidance with patient and community partners. That's a power shift, from assumptions about people's context to transparent asking, explaining why, and using the answers to improve care. ICD coding is where clinical power meets data structure. Administrative data sets don't see a person. They see documentation translated into codes using standards and judgment. A qualitative study of chart coders in Alberta found barriers to coding quality, unclear documentation, variability in interpretation, and quota pressures that limit time for nuance, all disproportionately impacting under-resourced centers, thereby exacerbating inequities. Coding standards aim to manage this by defining diagnosis types and expectations for specificity. For this module, it's worth exploring code families that can be more subjective or context-dependent, like mental and behavioral disorder codes, and factors influencing health status and contact with health services categories that can capture social circumstances when they're documented. ICD codes perpetuate biomedical models of health and are rooted in a deficit-based system. Let's translate insight into practice by role. For community partners, describe what safe, respectful care looks like locally and flag routine steps that create harm, such as at intake, triage, or discharge. For data scientists, document the data generation story, test for differential missingness, and avoid treating administrative data as neutral ground truth. For policy analysts, focus on upstream levers, training, accountability, resourcing of primary care, and policies that reduce gatekeeping. Our measures and models need to be accountable to lived experience, not just what's easiest to code. To close, let's return to purpose, improving how people move through the health system and improving the data trail that journey leaves behind. One practical next step is local. Find a community-led report or qualitative summary on health system experiences in your region and partner with them to ask what patterns in your data set could reflect those realities. Final takeaway, power dynamics aren't extra context. They shape care and they shape what ends up coded, missing, or misinterpreted in administrative data. It's just good science.